Hello, everyone. Can folks hear me? This doesn't seem to be on.
No,
not that one.
Yeah,
Oh, this one. Oh, sorry. Oh, right. Hi. Hi. Ooh, yeah. That makes my voice sound nicer. I'm really excited to be here today in person. Thanks everyone who are here in person and having a wonderful lunch. I just had mine. It's a special treat for me to introduce Dr. Sara Chung. She's a licensed clinical psychologist and postdoctoral scholar in the Hyperactivity, Attention, and Learning Problems Help Program here at UCSF. Dr. Chung received her PhD in clinical psychology at UC Berkeley. Go Bears! Dr. Chung's research program is centered on improving mental health treatment utilization and outcomes in Asian American families. Her recent work examines, I should put my glasses on. Oh, that's much better. Her recent work examines treatment barriers and predictors of treatment outcomes for children with attention and behavioral challenges. Dr. Chung's research has also examined culturally relevant parenting behaviors in bilingual, bicultural families and the implementation of accessible ADHD treatment in school settings. I'm also really stoked to say that Dr. Chung will be joining us very shortly as a faculty member in our department. All right, take it away.
Hi, everyone. It's so great to be here. What a privilege. My name is Sara Chung. I am a postdoc here at UCSF. And it's really great to see you all and talk to you today about insights into ADHD, understanding disparities in Asian American, and I'm going to tack on and Native Hawaiian and other Pacific Islander communities. And so before we begin, I wanted to acknowledge that we're on the traditional unceded land of the Ohlone Ramaytush people. Sorry. Alicia, next slide. Thanks. And I have no conflicts of interest. And then next slide, thanks. All right, so the objectives for today is to review recent data on ADHD diagnostic treatment disparities in Asian American, Native Hawaiian, and other Pacific Islanders, and to discuss the predominant rationale for what we might be seeing in terms of the numbers, and to understand the characteristics of ADHD treatment engagement in community samples, as well as applying then at the end recent data on treatment barriers to improve treatment engagement and effectiveness. And so disclaimer alert, because there is little data on AA and NHPI communities in the ADHD literature, I'll be zooming out to talk more broadly about AA and NHPI mental health. All right, so to give a bit of context, I wanted to start by describing these communities in the US today. The AA and NHPI communities make up about 7.4% of today's national population. And we're projected to outnumber Latina immigrants by 2065 to be the largest immigrant group in the nation. The broader community encompasses 37 ethnocultural groups, so the largest 5 being at the top Chinese, except Taiwanese, Asian Indian, Filipino, Vietnamese, and Korean. And approximately a quarter of this community live in multi-generational households. And in California, AA and NHPIs make up 15.5% of the state's population. And much of this community experiences limited English proficiency with rates of over 40% in Korean, Chinese, Bhutanese, Thai, Mongolian, Vietnamese, and Burmese communities. So let's get into what the disparities currently look like. And in comparison to white children, youth, racial and ethnic minoritized youth historically and are still experiencing diagnostic disparities. A study by She and colleagues that looked at insurance claims in a sample of over 230,000 children found that by age 12, compared to white youth, Black children were 17% less likely to have received a diagnosis. Latina children, 23%, and Asian children were 52% less likely to have received a diagnosis. Similarly, Adams and colleagues studied insurance claims for members of a large commercial and public health coverage plans, which yielded a sample of over 4 million youth and young adults ages 12 to 25. And they found that for 12 to 14-year-olds, all the way at the left on that graph, compared to white youth, Black youth were 23% less likely to receive a diagnosis. Latina youth, 44%, and Asian youth were 71%. So at an even higher discrepancy. The gap narrows just slightly moving into adulthood, but mainly due to a drop in diagnostic rates in the other three groups, rather than an increase in the Asian group. And there's virtually no data on ADHD and NHPI communities, and that's something I wanted to highlight today. The one study by Winston Chung and colleagues in 2019 showed that between the years, the next slide, thanks. Between the years of 2007 and 2016, ADHD diagnostic rates among children and adults were very similar to that of Asian Americans. And in terms of treatment, Xi's study on children 12 and under showed that Asian children were the least likely of the four groups to receive any treatment following their diagnosis, being 46% less likely than white children to receive any treatment within the first year. And this disparity is similar to those experienced by Latina children. Similar results were found in another study with a bigger gap for medication use specifically. And the good news is that for older youth and in adulthood, the trends seem to shift. So these graphs represent the rates of treatment use on the very left, medication and psychosocial treatment combined, then in the middle, medication only, and at the very right, psychosocial treatment. And while Asian youth have lower rates of medication use in early adolescence, the graph that says B, their rates become more similar to white youth as they get older. What's more, the rates are slightly higher than all racial groups for psychosocial treatment at these stages. For the NHPI community, though, again, there's no data on treatment. In a comprehensive review of psychosocial treatment studies for youth with ADHD that yielded 126 studies with a total of 10,604 participants, Maryland colleagues found that 151 participants were Asian, representing 1.5% of all participants, and only one participant was identified as NHPI, just one. And I want to acknowledge that Asian, Indian, and Alaska Natives are also drastically underrepresented in ADHD research with a total of 8 identified participants. Given the importance of early treatment to prevent or curb negative consequences of ADHD, I think it's important to understand why the drastic gap for AA and NHPI children. In the next section, I can only speak to Asian communities because of the total lack of data in NHPI communities. For Asians, the studies accounting for insurance, region, household income still found differences. And so those are some of the common important structural barriers that we hear about over and over again that contribute to these disparities, and yet they aren't fully explaining the gap. So let's take a look at some other rationale that have been posed as unique explanations for these communities. So myth or fact, Asians don't have ADHD. Yeah, I knew you would all guess correctly. Well, to see if this is true, let's just go with it, right? Let's turn to some findings from Asia. Because if Asian Americans indeed don't have ADHD, the prevalence of ADHD in Asia then should be at the same rates, right? So in this graph, the light blue bars represent the lower estimates, whereas the darker blue represents the higher estimates. And across East Asia, we're seeing estimates of 4.7 and 10.1. In Southeast Asia, we're seeing estimates of about 6%, and South Asia, a pooled estimate of 6.2%. So as such, the prevalence of ADHD in Greater Asia is estimated to be much closer to our national average, which again are higher in current diagnostic rates than Asian Americans. So I think it's safe to say that we're categorizing this in the myth. Let's touch briefly on this rationale. Asians are more likely to have ADHD, an attentive type, which, because it's not as disruptive as hyperactive, impulsive type, are thus then harder to recognize. So before I move into talking about this rationale for anyone in the audience who isn't as familiar with ADHD, there are 18 symptoms on the left-hand category. 9 of them fall into the ADHD inattentive type. And so to meet criteria, you need to show 6 of these symptoms in childhood. And on the other side is the hyperactive, impulsive symptoms. 6 of those of the 9 symptoms will lead to ADHD HI, hyperactive impulsive type diagnosis. Of course, there must be cross-context impairment, and you can also meet criteria for both and be diagnosed as combined type with 12 out of the 18 symptoms. Let's go back to that FANG study that came out this year. They put together a nice chart on ADHD subtypes. And looking at the very top at the Wilcott and DuPaul studies, we see that globally combined type may be the most prevalent, but in the US, the majority of youth are diagnosed with inattentive type. Now taking a look at the pool of studies done in Asia that included a look at the presentation types, we see 7 studies identifying ADHD-I as most prevalent. That's the ones in red. 2 studies, HI as most prevalent, and 5 reporting combined type as most prevalent. But the important thing to note here is that the pooled prevalence for youth in Asia somewhat favors ADHD inattentive type with combined type as the next most prevalent, but the proportional representation of presentation type in Asian children are actually really similar to those found among all children in the US. So this is somewhat true, but seemingly not more so than all children in the US. And the question of the diagnostic gap remains unanswered. Let's take a look at this one. This is a common rationale for ethnically minoritized families. Asian parents have limited knowledge of ADHD and aren't identifying a problem. As Araldi and colleagues propose, the model of help seeking begins with recognizing the problem. So maybe in Asia, teachers and doctors and other adults in the lives of the children are recognizing ADHD, but perhaps the Asian parents don't know that as much about ADHD and aren't identifying the problem for themselves, but that's how they're getting funneled into the system anyway through other adult recognition. And so a couple of studies in Vietnam showed that parents were slightly less likely than teachers to endorse ADHD in their children, but the ratings were generally in agreement with their teachers. You see that in the top graph, the very right. Another study found that the rates of ADHD were much higher in urban areas at 14.9%, compared to rural areas, 6.7%. And so there's variability depending on the contextual demands of the family and the children. But at the same time, those rates were much higher than the rates here. And in Japan, Yamauchi's study found that the mean age of parents' first concern about their child's symptoms was 5.6 years old, which is very similar to the mean age found in other non-Asian populations. But the mean time lag between parents' initial concern and their first visit to seek help for ADHD concerns was almost 3 years. So parents reported major barriers were not having a referral, not knowing where to seek appropriate services, and lower maternal education was also found to predict that longer time lag. There's no prevalence data on neurological conditions in the Philippines, but I thought this one was interesting. Alonso and colleagues looked at Google searches as a proxy of public health. Although this isn't limited to parents, you'll see that ADHD is at the very top with over 110,000 monthly searches. Interestingly, in comparison though, ADHD is the second lowest in the average bid amount, which is how much advertisers are spending on each condition and used as a proxy for the priorities of the healthcare industry. And so there's a mismatch there. And here's some evidence against the idea that Asian parents don't consider these symptoms a problem. Comparing parents in the UK to parents in Hong Kong parents rated their kids as having more ADHD symptoms than those in the UK, despite having objectively lower activity levels. That was tracked by a wearable activity tracker. And Hong Kong parents thus had what the researchers called a lower rating threshold than UK parents, meaning they had a lower tolerance for what they considered as ADHD. Parents also rated themselves higher in parenting stress related to their children's behavior problems and slightly higher authoritarian parenting compared to UK parents. That's a common theme. And when looking at what could explain the differences in ADHD rating threshold, these researchers found that higher stress experienced by Hong Kong parents related to their child's behavior problems predicted a lower tolerance for symptoms. And so their findings suggest that some Asian parents are bothered by the behavior issues related to ADHD, and this particular subgroup even more so compared to the non-Asian parents. And that little data from the US, the little data in the US, showed that Asian Indian parents were less likely to recognize ADHD given a vignette, despite reporting slightly higher ADHD symptoms in their children than white parents. Their ratings for their children's symptoms all fell within the 99th percentile across inattention and hyperactivity impulsivity. On the other hand, recognition of ADHD was found to be significantly related to parents' intentions to seek help. So there's that evidence there. Importantly, the authors found that higher stigma predicted lower help-seeking intentions in Asian Indian parents, whereas higher perceived control predicted higher intentions in the European American parents. In other words, barriers like stigma was more important for Asian Indian parents in terms of help seeking. How they perceive their ability to overcome barriers to help seeking were less important to these parents. So are Asian parents not identifying it as a problem? It depends on their background, and more data on Asian American parents is sorely needed. Perhaps some parents aren't recognizing ADHD as a disorder despite endorsing high rates of symptoms. Context matters in their ratings, and structural barriers like the priorities identified by medical systems and industries, stigma, and the lack of knowledge in navigating those systems are critical. And that brings us to the model minority myth. This is a structural barrier unique to Asian Americans, and the interaction between higher ADHD inattentive type prevalence and the model minority myth has been proposed as a driver of these disparities. So the model minority myth, for those of you unfamiliar, is an externally imposed perception of AA and NHPI as independently high achieving and free of psychological distress. In other words, all Asians are wealthy and healthy. This is a 1987 cover from Time magazine that I think visually captures that concept. The myth arose following two media articles that came out in 1966. The New York Times article called Success Story, Japanese American Style, and the US News and World Report Success Story in the US about Chinese Americans. The myth was used to pit Asians against other racial groups and shame other people of color to uphold structural inequalities during the civil rights movement. But it's still very much alive and well today. One consequence of this pervasive belief that all AA and NHPI are wealthy and healthy is that they're not in need of scientific or clinical attention. This belief is thought to maintain that historic underrepresentation of AA and HPI in research. In fact, Dwan and colleagues' critical look at the NIH budget allocations between the years of 1992 to 2018, a 26-year span, found that only 0.2% of NIH funding of clinical research projects included AA and NHPI. Many researchers think that as a result, our needs are drastically underreported. I think this theory best captures what we just talked about. It's a proposed model presented by Jacqueline Kim and colleagues. They propose that the model minority myth is an invisible cultural force shaping socio-ecological systems over time, and then that results in a bottlenecked understanding of AA and NHPI health and mental health. The constraints occur at multiple levels. At the first level, funding and policies. So we just talked about how AA and NHPI are represented in only 0.2% of NIH funding over the 26 years examined. And Asian American researchers are the only racial minority group excluded from eligibility for diversity-related NIH funding. Thanks in part to the model minority myth, AA and NHPIs have long been thought as a monolithic group, but aggregated data of this community totally overshadows the impacts of social determinants of health. As a primary example, the combined poverty rates of all Asian groups really obscures what's happening in reality. While Asian children as an aggregate show similar rates of poverty to white children, with NHPI facing poverty rates that are twice as high, looking then across the ethnic groups on your right, you see that 18 communities fall above the poverty rate for white children in 2021. That includes 6 of the largest Asian ethnic groups, which have the asterisk next to them. And right here in the San Francisco metro area, Sacramento, South Bay, and Santa Clara, we have some of the largest number of Asians living in poverty in the nation. Just wanted to take a brief moment to dispel the belief that educational attainment, which is highly valued in Asian cultures, equates to wealth and health. 1 in every 3 Asian adults who live in poverty have a bachelor's degree, compared to 14% for non-Asian adults. So at the second level, the model minority myth is proposed to also impact research and healthcare. And Kim and colleagues examined health psychology and behavioral medicine articles published between the years of 1900 to 2020 and found that less than 1% of studies mentioned Asian Americans. I'm going to venture a guess that that number is much smaller for NHPI communities. And as I mentioned earlier, coming back to ADHD research then, that rate is not much better for Asians and nothing is known about the NHPI community. When there's underrepresentation, especially of those with limited English proficiency, we are over-relying on samples who are already receiving care, who are open to it. We're excluding those who have never been screened, who have never been referred or diagnosed, or who drop out early. And this lack of accurate data on AA and NHPI impacts implicit bias in providers' decision-making. This is one example from the health literature, emergency pain management. Asians were least likely to receive a pain assessment and less likely than white patients to receive pain medication for traumatic injuries. And this breeds distrust in the system. As part of a statewide coalition with other California universities and community partners, I spoke to leaders of community-based organizations working with AA and NHPI communities across the state. This is a quote from an interview with a leader of an organization serving thousands of members. They described the reactions they got when referring community members to mental health services as, why am I filling out this form? What is it for? No, you're lying to me. And then they went on to describe the prevalence of mistrust in the system and the underreporting of significant issues, saying mistrust in government and authority is also big in Chinese culture, but that's never talked about. I don't know why, but that's talked about in the African American. That's talked about in the Latinx communities. But for us Asian folks, we trust the system, air quotes. But no, we don't. We don't even call the cops when my mom's getting beat, right? Domestic violence is one of the most prevalent things, but again, it doesn't show up. It's underreported. The limited funding opportunities at level 1, the underrepresentation in research at level 2, the bias in healthcare settings at level 2, then influences the public perceptions of AA and NHPI. This is in both how people from other racial and ethnic communities perceive AA and NHPI and how we perceive ourselves. There are two ways that the myth impacts ADHD diagnosis and treatment. Potentially, they've been proposed. The first explanation is under-identification in the classroom. And so the myths of Asians being docile and overachieving runs really counter to teachers' perceptions of how kids with ADHD behave and function properly or function academically. The data is mixed, but here's an example of support of this theory. Controlling for family structure and income, Asian students were less likely than white, Black, and Latina students to receive a teacher referral for ADHD services. Teachers also rated Asians as having fewer inattention and behavior issues than Black and white students. And these findings posted up here mirror the ones that Anna Lau found 15 years prior to this one, that found that teachers reported fewer externalizing problems in Asian youth, despite running contrary to the youth's own self-report. So internalized minority myth in Asian American and Native Hawaiian Pacific Islanders increases ADHD stigma. The second explanation that the internalization comes from evidence found in non-ADHD literature. The top is an example of Asian American suicide survivors. While there's no published data on this in the ADHD research, the idea is that the myth fosters the belief that children's low academic performance and behavioral issues are a result of poor parenting. Because if all other Asians are doing great, it must be a you problem, right? This is an example from a recent qualitative study on the experience of ADHD and racially and ethnically minoritized youth. People have joked that because I'm Asian, I should do better. I think it nicely sums up the public perception that's happening, potentially as a result of the myth. So I just spent a long time talking about how little data there is about model minority myths' impact on ADHD treatment and about the lack of knowledge on the experience of ADHD in AA and NHPI in general. I appreciate you all bearing with me. Now I'm going to switch gears to share a bit about what we're beginning to see. And so this is data that I'm really excited about. This data I'm presenting is hot off the presses. This is the first look here. This is in collaboration with Drs. Patrick Go at the University of Hawaii at Manoa and Amori Makami at the University of British Columbia. Data collection is ongoing, but we already have a sample of over 1,000 university students. The project aimed to take advantage of one of the locations, University of Hawaii. And we wanted to collect the largest NHPI sample that's ever been examined. The goal was to recruit equal numbers of AA and NHPI to white participants with and without ADHD. Because so many Asians and NHPI don't actually have a diagnosis, they were included in the study if they suspected they had ADHD. They then were asked a number of things, including to report on ADHD symptoms and impairment across contexts. And the entire sample right now includes over 450 Asians and almost 100 NHPI. And among the Asian students, over 15 countries are being represented, with the highest representation being Chinese, Filipino, and Japanese students. The NHPI subsample includes 56 Native Hawaiians and 36 other Pacific Islanders. Data collection is ongoing, so we're seeing increases here. And of course, despite our best efforts to recruit equal amounts with and without actual diagnosis, the rates for Asian NHPI diagnoses were unsurprisingly much lower in the sample. So in the full sample, NHPI didn't differ from white students in their model minority myth beliefs, but Asians there in the blue bars reported significantly higher beliefs in both groups, suggesting an internalization of the myth in Asians. And Asians and NHPI endorsed similar rates of ADHD stigma as well, which were then significantly higher than white students. Other students of color, we had to collapse that group because of the lower numbers and representation there. Those are the bars in yellow. They endorse similar levels of both model minority myth and stigma as the white students. And we were interested in looking at what might predict the model minority beliefs. Heritage culture seems to be important here. So heritage culture is measuring the extent to which people engage in their culture of their country of origin in terms of their values, beliefs, practices, social relationships, and cultural activities. So in a regression model, we see an interaction effect of heritage culture and racial group. This effect indicates that heritage culture is protective potentially against the myth in both white, who are in the red line, and NHPI, the line in purple. But in Asians, who are represented by the blue lines, heritage culture is positively associated with higher myth beliefs. And among those recruited, we saw about a third who had a history of self-reported ADHD. That means they either reported a past diagnosis or met self-reported criteria of symptoms plus cross-context impairment. And we wanted to understand racial group differences in treatment experience in those with self-reported past ADHD history. So this subsample was then categorized into 3 treatment-seeking groups. In red are those who met criteria but did not seek a past diagnosis or treatment yet. That's our no treatment history group. In blue are those who reported a past diagnosis and treatment and no longer met self-reported criteria. That's what we're calling our successful group. And in green are those who reported a past diagnosis and treatment but still met criteria. That's what we're calling our unsuccessful group, unless someone has a better name for that. The proportion of Asians across the 3 treatment types significantly differed from white students. 21% of Asians had sought treatment compared to 41% of the white students. And unfortunately, the number of NHPI as of now were too low to be able to detect differences. So just looking then at the Asians with an ADHD history, the successful group here in green, now at the very left, reported significantly lower ADHD stigma compared to the no treatment and unsuccessful groups. Because this is cross-sectional data, we can't tease apart the direction of this relationship. One explanation is that not experiencing success in treatment increases stigma, right? The belief that ADHD means you're inherently flawed gets worse, gets strengthened after you tried in treatment and failed potentially to fix it. The other explanation is that those who went into treatment with higher stigma were more likely to not get as much out of treatment. So stigma was a barrier to treatment engagement and outcomes. And we're collecting ecological momentary data, so more to come on this. We see a similar pattern in the NHPI students, but again, the power is undersampled, so hopefully more to come. And lastly, to understand if the model minority myth beliefs might impact internalized stigma among those with a history of ADHD, we found a positive relationship between myth beliefs and stigma that was unique for Asian Americans compared to NHPI. So this relationship was not true for NHPI. So potentially these very preliminary findings lend some support to suggesting that Asians high in heritage culture may be at higher risk for the model minority myth beliefs and the negative outcomes of them. Internalization of the myth beliefs in Asians may increase ADHD stigma, which in turn could not only inhibit treatment access, but treatment engagement. And this relationship appears unique in Asians, so we need to examine NHPI separately. So more to come. So lastly, I want to share some published data on predictors of ADHD treatment, engagement, outcomes among Asian parents. This work is on treatment engagement among parents in clinical settings who participated in behavioral treatments for ADHD. This is in collaboration with Dr. Linda Pfeiffer and Dr. Steve Hinshaw. This work was done at our very own health clinic and across the Bay at Cal. Of the total 199 participants in the sample, we had a small sample of Asian parents and other minoritized parents. The large majority were white parents. Based on the Rosenstock Health Belief Model, we looked at pre-treatment barriers related to help seeking. And we found that Asian parents endorsed lower parental self-competence. That's how confident they felt as parents, parenting the child that they have, and lower treatment expectations than both white and other minoritized parents. They expected to get less out of treatment right from the start. Then when we examined how pre-treatment barriers contributed to engagement and treatment outcomes, we found that for all parents, treatment expectations predicted engagement, which then in turn predicted children's global improvement as reported by the parents. Even when accounting for this though, Asian parents still reported lower improvement in ADHD symptoms compared to white parents and lower global improvement compared to other minoritized parents. And so in our sample, our findings suggest that Asian American parents saw attenuated child improvement with behavioral treatment. Our findings also indicate a potential downstream effect of treatment expectations for Asian parents who began treatment with the lowest expectations. And while this preliminary work on a small sample, this is a preliminary study on a small sample of Asian Americans, the study lends some support to using the health belief model as a framework for understanding and studying Asian American engagement with behavioral treatments. As with all that work, there's several limitations to the work that I just shared. The worst offenders being the reliance on cross-sectional data in the first study currently, the small clinical sample in the second study, and across both studies, we did not have the room and the power to analyze across ethnic groups. And so we're starting to see that ability with the data being collected from the University of Hawaii and UBC. And so more to come on that, but again, their reliance on aggregated samples across all the ethnic groups. So what do we do with all this information and how do we use it in the clinical context? And before I get there, I didn't prepare slides for that, but I wanted to give just a sneak preview in a smaller sample looking at our school data and implementing these treatments at school. We're seeing higher levels of recruitment in Asian American parents, higher engagement in the treatment, and we're seeing that they are utilizing some of the skills that we talk about at the same rates, if not more, than white parents. So it's promising in the community context. All right. So I have a few ideas and definitely open to others. To start, there's some indication that Asians have less knowledge about ADHD, aren't recognizing the symptoms as a disorder, providing psychoeducational materials about ADHD in other settings like primary care, community health organizations, and schools can reach parents outside of the clinic. And importantly, given the high rates of limited English proficiency in this group, as well as the high rates of families living in multi-generational households, we really have to consider translated materials being disseminated out in community centers to broaden that knowledge base in the older generations of adults living in the same home and households. And sharing this knowledge with teachers can help with identification issues. And so in my graduate program at Cal, I did some work looking at low income Chinese immigrant and Mexican Americans and going out to the Head Start programs to talk about social emotional behaviors, translating that material to the families. And just anecdotally, but we did get good engagement, a lot of curiosity, and a lot of questions coming about child development and emotional development from the community. And when these families are in your door, start with assessing pretreatment factors that are related to engagement. To keep parents engaged, researchers like Maya and Kristen McCabe in San Diego have looked at assessing factors before treatment begins to identify barriers and to then fold key cultural practices into treatment and try to bolster those before treatment even begins. And so they're hoping to circumvent those interpersonal barriers. And so far, their data looks pretty good at increasing attendance and engagement. And assessing things like treatment expectations, cultural values, beliefs, and practices related to parenting all seem to be really important conversations for all of our patients, but appear even more so, more central to at least behavioral treatments for Asian parents. And given the implications of the model minority myth on stigma, treatment outcomes, perceived discrimination, acknowledge biases, especially for those many Asian Americans and IHPI living in multi-generational households, understanding and then revisiting how close loved ones may be inadvertently stigmatizing your patient or inhibiting their everyday skill practice is an important discussion to keep in mind. So keep having those conversations, introduce it at the beginning and check in and keep checking in to bolster their outcomes. And last but certainly not least, we need to address the structural barriers for these communities, the high amounts of limited English proficiency, the high rates of poverty in these communities in our neighborhood, and the high rates of public health coverage in these communities means that we need to make linguistically matched, low-cost services available now. And with that, I just wanted to give a big thank you to the UCSF Help team, mentors, collaborators on all these projects, including collaborators across the California universities not listed here who are part of the California Alliance on Mental Health. Thank you.
Thank you, Dr. Chung, for such a fantastic talk. We're going to take some questions here in the audience first. I'm going to look at to you, Dr. Glowinski.
Hi, Sarah.
Hi.
So I'm so excited that I think you're joining us soon, right? And so very excited about that. You gave us a really comprehensive panopticon, of what you thought about. And because there are measurement issues potentially, right? Like how you measure in a certain country. One question I have is there a possibility, or have you ruled out that there are behavior expectations that still influence what behaviors are observed at schools? Because I think teachers are actually better than self-reports by kids, usually, right? And I was wondering if, like you could even look at, are there higher rates of false positives? on symptoms of ODD. That would be a sort of proxy for these differential expectations, maybe. And then have you accounted, what data do we have about differential use of alternative treatments for all of medicine in general in the communities that you are particularly invested in, and whether that's actually happening for ADHD? I don't know the answer. And whether that's not reported as treatment would be another question. Thank you.
Thank you for asking.
Sarah, can you
Yeah.
repeat the two questions for our audience on Zoom?
Yeah, so the first question was about potentially ruling out behavioral expectations in that context. And so I think what you're getting at on there is thinking about the cultural expectations that might be occurring in Asia versus the US, what teachers are expecting in the classroom, and potentially seeing more disruptive behaviors in the classroom are more important here than the behaviors of inattention in Asia, for example. The other question is what types of treatments are out there for these community samples that are maybe even broader for mental health and health that are being disseminated? That second question is so important for ADHD. I cannot answer that. I would love to learn more about that, potentially think about it for a future project. But to answer the first question, I'm so glad you brought that up because cultural expectations are very important. And so that's why one of the explanations for Asian parents seeing more behavior issues, rating their child as more symptomatic than the UK parents, because there's this expectation potentially in many Asian cultures and ethnic backgrounds about children being well-behaved, humble, and following the rules within the collectivistic society. So when you're in a collectivistic society and working in a group context, you're expected to be more considerate of those around you. And so potentially seeing less behavioral issues and in these kids. And yet the key here is the impairment at home. Because if the parents are seeing this, and it's important to Asian cultures, then the impairment at home is really important and felt by the family. And my previous work looking within the Chinese American immigrant population and parent-child conflict, I found that compared to non-Asian populations, that even just moderate amounts of conflict in the home was a predictor of problems, of internalizing issues in these kids. And so we're seeing that there are outcomes that are coming from what's expected of them. And so thinking about how we can reach parents and get them in and talk about these issues too. Yeah.
I have a question. Given the language needs of this population that you so eloquently illustrated, and given the fact that at least for the psychologist workforce in the United States, less than 5% of psychologists are bilingual in any language, how would you go about meeting that particular need?
Oh gosh. If I know, I would definitely implement it right now. So speaking with the community-based organizations, one of the systems that they've implemented is recruiting early. And so they put into place bilingual interns and trainees and having a program in which they are supported through a pipeline and then reconnected with the organization as they choose to go into getting their graduate degrees and potentially becoming licensed clinicians. And so these organizations are trying to support these trainees along the way. And I think that's really beautiful. There is a huge need. We had the interpreter training services discussion and training. And I think that is potentially one way. Of course, there are many challenges with using those services as well. But when talking to these organizations, because there are so few bilingual providers, they are so burnt out and the turnover is so high. One organization told me that they removed all barriers to scheduling patients. So if they just asked, if the patient asked for help, they were put onto a clinician schedule. And these clinicians were working 12, 13-hour days to meet the demand. And so the demand is being seen out there.
Hi, thank you. This was amazing and really well organized. I was really struck by the non-response, self-reported non-response rate. And I know you gave a great explanation of that for behavioral treatments, but is it also true for psychopharm treatments? And if so, do you know if there are any other factors at play?
Oh, I would love to know the answer to that question. So the short answer is that I don't know. I feel like I want to look it up right after this talk because it's so important. What I do know is that there's medication. So accessing medication, those rates are even lower within the Asian community because there is a lot of stigma around that. That's still alive and well. Speaking to interviewing these leaders at these organizations, one leader said that when bringing up medication, it was eliciting this connotation of a sane asylum in Asia. And so it's immediately connected to like, what's wrong with my child? They're not crazy. And so there's work to be done there. Yeah.
We have some questions in the chat. Let's see. Sorry. Yeah, Michelle Foy, you can unmute yourself. Or I'll ask the question. All right, could higher treatment rates in majority groups actually be over treatment? For example, maybe lower threshold for starting meds versus trying CBT first.
Yeah, I think that's a great question. And I think that could certainly be a rationale for that. And so I'm not familiar with the literature on that, but I would also be interested to know if anyone in the audience or on Zoom is able to answer that question.
And we have one. Sorry, bear with me, folks. I'm just trying to organize myself here. So I'm wondering, so this is Amanda. Amanda, are you still there? You want to, nope, okay. Well, this was Amanda's question. I'm wondering if there's any plans, hopes in the Hawaii BC study to disaggregate the Asian group by ethnicity.
Very much so. Exactly, very much so. And so we're seeing pretty good representation of East Asian and Southeast Asian, but we are trying to increase the numbers for South Asians and of course the NHPI community. Hopefully the study will run for a number of years. So just within the first year, we have over 1,000 participants. And if it is able to continue for the next several years, we're looking at 4,000 to 5,000.
Wow. Any other questions in the group here? I'm trying to balance. Okay. Oh, Dr. King. Okay, hang on.
Seize the moment. Thank you for a wonderful talk. I'm coming back to the question about treatment response and wonder if anyone's looked at the influence of MMM on response to treatment, particularly pharmacotherapy, and thinking there could be a bias toward more likelihood of responding, either because teachers, who you said may be less likely to report these symptoms, may be more likely to be seeing improvement, and or that's just how you're supposed to behave. Like, you know,
Yeah.
if you take a medicine, you're supposed to get better.
Yeah. Oh, that's such an interesting question. Yeah, mono-minority myth on medication treatment. And I don't think there's anything out there. Again, the data is super, super limited, especially for this racial ethnic group. But I think that would be just really interesting to look at and thinking about how the expectations behind the myth and what's driving the negative outcomes related to the myth could potentially increase the response to medication. I'm just thinking out loud here, but yeah, thank you for sharing that curiosity.
So we have several comments in the chat, and we'll save them for you. We'll pass them along to you, Dr. Chung. This was a fantastic presentation, amazing work that will continue here at UCSF and with your collaborators. This is fantastic. Any other questions in the audience that we can field? Yes, okay. You have 2 minutes. Use them wisely.
Thank you for your talk. And I think it's such an important and often invisible topic, so I'm really happy to hear it. I'm wondering, are you collecting data or thinking at all about how not just model minority myth, but also the burden of intergenerational trauma experienced in these families might affect treatment expectations and response?
Yes, you should see the whole list of the survey that we have. There's so much in that data and so many curiosities for this group, right, that we're trying to capture because there's no data. So we're taking full advantage and seeing really great responses. These students are filling it out. They're doing the EMA study for 28 days straight. We're getting response rates of like 80%. And so I think that this topic is just a really big topic of interest in these communities.
Thank you so much. And that concludes today's Capcan Grounds. Thank you so much
Thank
for being
you
here.
for being here.